You know, when you watch a newborn, those tiny little leg kicks and hip wiggles, they seem random, but they're actually super important for their development.
Absolutely. Healthy movement is key right from the start.
Exactly. And today, we're going to dive into something that can sometimes affect that early movement, specifically around the hip. It's congenital dislocation of the hip.
Or, as you'll often hear it called now, DDH, developmental dysplasia of the hip.
Right, DDH. We've got some pretty comprehensive notes here, and the plan is, well, to really pull out the crucial bits, make it clear, make it memorable.
Yeah, give you a really solid understanding. It's important stuff. DDH affects roughly 2 out of every 1,000 babies born.
Okay.
Though it's interesting, simple hip instability is more common, maybe 20 per 1,000 newborns. But often that sorts itself out in the first few weeks.
Okay. So that transient instability is different.
Exactly. What we want to focus on today is the more persistent DDH. Think of this chat as like your high-yield guide, the core info you really need to grasp.
Perfect. So let's start right at the beginning. In simple terms, what is congenital dislocation of the hip, or DDH?
Okay, so put simply, it's a condition where the hip joint, the ball and socket doesn't form correctly while the baby is developing.
In the womb?
Yeah, during pregnancy. And this means that at birth, the hip might be unstable, partially dislocated.
That's subluxation, right?
Right. Subluxation is partial dislocation. Or it could be completely dislocated, where the ball part, the head of the femur, is totally out of the hip socket.
Got it. So it's a developmental issue, a musculoskeletal thing, and it exists on a spectrum.
Precisely. From just a bit wobbly to completely out.
And do we know what causes this? What's the etiology?
Well, that's a tricky part. The exact cause isn't fully understood.
Ah.
Research is looking into things like specific genes, even the forces inside the uterus. But right now, the consensus is it's likely a mix.
A mix of what?
A combination of genetic factors, so maybe a family predisposition and environmental influences during pregnancy.
Okay, so no single smoking gun, but maybe a combination of hits. Are there known factors that make it more likely then? Risk factors.
Oh, definitely. There are several well-established risk factors. One of the big ones is breech presentation.
So baby being bottom or feet down instead of head down?
Exactly. Also, being female carries a higher risk. Family history is important, too, if a close relative had DDH. Being the firstborn child is another factor, and oligohydramnios.
Which is less amniotic fluid than usual.
Correct. And finally, certain genetic syndromes can also be associated with it.
Wow, okay, that's quite a list. Breech, female family history, firstborn oligohydramnios, genetic syndromes. Any way to easily remember those?
There is. A little mnemonic. BFF first go.
BFF first go, like
Yeah.
best friend forever.
Yeah, B for breech, F for female, F for family history, first for firstborn, G for genetics, and O for oligohydramnios.
BFF first go. I like it. Catchy. Okay, so that covers the who might be more at risk. Let's talk about the pathophysiology. What's actually going wrong in the joint?
Right. So the core problem is that inadequate development during fetal growth. The hip socket, the acetabulum, is often shallower than it should be. Think of it like a saucer instead of a deep cup.
Okay, so it doesn't hold the ball as securely.
Exactly. That shallow socket makes it much easier for the femoral head, the ball to slip partly out, that's the subluxation we mentioned, or completely out, the dislocation.
And that instability, that poor fit, that's what can cause problems down the line.
Yes, precisely. It affects how the joint functions and can lead to long-term issues if not addressed.
Makes sense. Now, when a doctor is checking a baby, especially a newborn, are there other conditions that might look similar? What are the differential diagnoses we need to think about?
Good question. Yes. Definitely other things to consider. We already mentioned transient neonatal hip instability. The key there is transient. It usually gets better on its own.
Right.
Then there's septic arthritis, an infection in the joint. That's serious and usually comes with signs of infection like redness, warmth, maybe a fever.
Okay, infection.
Yeah.
What else?
Leg calvé-Perthes disease, that's another hip issue, but it affects the blood supply to the femoral head and usually shows up a bit later in childhood, not typically at birth.
Got it. Later onset.
Also, just generally, other hip joint infections need to be ruled out. And sometimes muscular torticollis, that's a neck muscle issue, can be associated, maybe due to positioning in the womb. So it might flag initial hip concerns, although it's a separate thing.
Okay, another list. Septic arthritis, transient instability, leg calvé-Perthes, other infections, maybe torticollis. Any memory aids for this one?
How about still hip? Like the hip is still causing concern.
Okay, let's try it. S.
S for septic arthritis.
T.
T for transient instability.
I.
I for infection. hip joint infections.
L?
For leg calvé perthes.
And the other L.
Let's say limber hip, just to represent that instability idea again. It's a bit forced, maybe.
Still hip. Septic transient infection, leg calvé limber hip. It works. Quirky, helps it stick sometimes. So we mentioned the overall rate is about 2 in 1,000 births. What about specifically here in the UK? What's the epidemiology say?
Yeah, the notes confirm that. Here in the UK, the prevalence is right around that mark, approximately 1 to 2 per 1,000 live births.
Okay. Now for the really practical stuff. What signs would actually make a clinician suspect DDH? What are the clinical features you look for?
Right. So in a newborn or young infant, the examination is key. You might actually feel instability in the hip through specific maneuvers. But other visual signs can include limited abduction, that's difficulty moving the baby's leg outwards, away from the body.
Okay.
You might also see asymmetry, uneven skin creases on the thighs or buttocks, the gluteal folds.
Ah, the fold asymmetry. I've heard of that.
Yes. And then there are the classic tests, the Ortolani and Barlow maneuvers.
Can you explain those briefly?
Sure. The Ortolani test tries to gently reduce a dislocated chip back into the socket. You might feel a clunk as it goes back in.
Okay, Ortolani is for reduction.
And the Barlow test does the opposite. It assesses if a hip that seems okay can be gently dislocated or pushed out of the socket. You feel for that instability or movement out.
Barlow is for provoking dislocation. Got it. Any other signs?
Well, in more obvious or maybe later diagnosed cases, you could see a difference in leg length.
And do these signs change as the child gets older?
Yes, they do. Those Ortolani and Barlow tests are most reliable in the first few months. After about, say, 3 months, they become less useful as the muscles tighten up.
So what do you look for then?
In older infants, limited abduction often becomes a more consistent sign. Also, the Galeazzi sign.
Galeazzi.
Yeah, you lay the baby on their back, bend their hips and knees with their feet flat together. If one knee looks lower than the other, that suggests the femur on that side might be shorter, potentially due to dislocation.
Okay, uneven knee heights. Makes sense.
You might still see the asymmetry in the gluteal or thigh folds. And as they start moving, delays in milestones like crawling or walking, maybe a limp, but often it's painless, which is interesting. Sometimes toe walking, falling more often, or maybe struggling to lift one leg when they try to crawl.
And even older, in walking children.
In older kids, you might see a positive Trendelenburg test. When they stand on the affected leg and lift the other one, the pelvis on the lifted side drops down. Normally, it should stay level or rise slightly.
Okay, that indicates weakness in the hip abductor muscles on the standing side, right? Because the hip isn't stable.
Exactly. It shows the joint isn't providing that stable pivot point.
So if any of these signs raise suspicion, what's the next step? Investigations.
The go-to investigation, especially for babies under about 6 months, is an ultrasound of the hips.
Why ultrasound?
Because the hip joint in infants is still largely cartilage, which doesn't show up well on X-ray, but is visualized beautifully with ultrasound. It's perfect for seeing the shape of the socket and the position of the femoral head.
It's used for screening too, right? In babies with risk factors.
Yes. If DDH is suspected clinically in a newborn, an ultrasound should ideally happen within 2 weeks. And even if the exam is normal but risk factors are present like breech birth or family history, an ultrasound is often recommended, usually before 6 weeks of age.
What about older babies or children? Over 6 months.
Then X-rays become more useful because the bones have started to ossify, to harden, so they show up clearly.
What kind of X-ray?
Typically an anterior-posterior or AP view of the pelvis.
And what are you looking for in the X-ray?
You're looking for signs like that shallow acetabulum we talked about. Maybe the femoral head looks underdeveloped or isn't positioned correctly within the socket. And doctors also look at something called Shenton's line.
Shenton's line.
Yeah, it's an imaginary curved line you trace on the X-ray, following the inner edge of the femoral neck up to the lower edge of the bone above the socket, the superior pubic ramus. In a normal hip, it should be a smooth, continuous arc.
And in DDH?
In DDH, if the hip is subluxated or dislocated, that line will be broken or disrupted. It's a key indicator of abnormal alignment.
Okay, that's clear. Ultrasound for the little ones, X-ray for the older ones, looking for specific features like the socket shape and Shenton's line. So let's say the diagnosis is confirmed. What's the plan then? How is DDH managed?
Management really hinges on the severity and, crucially, the child's age at diagnosis.
Makes sense.
The main options are basically observation for very mild, stable cases that might resolve or active treatment with bracing or potentially surgery.
And no medications help here.
No, there's no pharmacological treatment. It's all mechanical or structural. The absolute key, as we keep saying, is early diagnosis and getting the child seen quickly by a pediatric orthopedic surgeon.
Right. So what are the specific treatments? You mentioned bracing.
For infants under 6 months, the standard first-line treatment is usually the Pavlik harness.
I've seen pictures of those. Looks like little straps.
Yeah, it's a soft harness that holds the baby's hips flexed, bent up, and abducted, spread apart slightly, kind of like a frog's legs.
And how does that help?
That position gently encourages the head of the femur to sit deeply within the acetabulum, promoting proper development of the socket around it. It guides the hip into the right place as it grows.
Okay. And if the harness doesn't work, or if the child is diagnosed later,
then surgery might be needed. This could be a closed reduction where the surgeon manipulates the hip back into the socket under anesthesia, often followed by a cast. Or it might need an open reduction where they actually make an incision to physically put the hip back in place and maybe deepen the socket.
and that involves a cast afterwards too.
Yes, usually a special type of cast called a hip spica cast is needed for several weeks or months to hold everything in position while it heals, and sometimes further surgeries might be needed later on.
Are there risks with the surgery?
Well, like any surgery, there are risks. One specific concern with hip surgery in children is avascular necrosis, or AVN.
That's the blood supply issue again.
Yes, potentially disrupting the blood supply to the femoral head, which can cause problems with the bone later. It's something surgeons are very careful to minimize, but it is a risk.
Got it. And the notes mentioned something about swaddling.
Ah, yes. There's some evidence that very tight swaddling, where the legs are held straight and together, might slightly increase the risk or worsen mild dysplasia. So the advice is usually hip-healthy swaddling, allowing room for the legs to bend up and out.
Good tip. And swimming.
Swimming is often recommended later on. It's great exercise, low impact, and encourages good range of motion in the hips.
So looking ahead, what's the typical outcome? The prognosis.
It really varies. Depends heavily on how severe the DDH was initially, how old the child was when treatment started, and how well the treatment worked.
Generally.
Generally, the earlier you catch it and treat it effectively, the better the long-term prognosis. Many children treated early with something like a Pavlik harness go on to have perfectly normal hips.
That's encouraging. But what if it's missed? Or treatment isn't fully successful? What are the potential complications?
If DDH isn't treated or isn't treated adequately, it can definitely lead to problems later. The hip might remain unstable.
Okay.
The dysplasia, the abnormal shape of the joint, can persist or worsen. And the big long-term concern is early onset osteoarthritis.
Wear and tear on the poorly formed joint.
Exactly. Because the joint surfaces don't fit well, they wear down much faster, leading to pain, stiffness, and loss of function, potentially quite early in adulthood.
So significant functional impairment down the road.
Yes, it can really impact mobility and quality of life if left unmanaged.
It really hammers home why those newborn hip checks are so standard and so important. Getting that early detection is vital.
Absolutely crucial.
Okay, this has been incredibly helpful. A really clear walkthrough of DDH based on these notes.
Good. So just to quickly recap the key points. DDH is about the hip joint not forming right, ranging from instability to dislocation. Risk factors include breech, female sex, family history. Diagnosis relies on clinical exam or Ortolani, Barlow, later signs like limited abduction or Galeazzi confirmed often by ultrasound in infants or X-ray later. And treatment.
Treatment depends on age and severity, often starting with the Pavlik harness for babies under 6 months. Surgery may be needed if that fails, or for older kids. Early treatment is key for the best outcome and avoiding long-term issues like early arthritis.
Perfect summary. Makes you think, though. Given the potential long-term impact, especially that risk of osteoarthritis, you wonder what's next. Are there big advancements coming in, say, screening? Or maybe even better, non-surgical ways to manage it?
That's a great question. It's certainly a very active area for research, improving screening accuracy, refining harness techniques, exploring biologics. Lots of potential for the future.
Something to keep an eye on. Well, that wraps up our deep dive into congenital dislocation of the hip. We hope this discussion has given you a clear, high-yield overview.
Hope it was useful.
And remember, for more great revision resources and materials, definitely check out pastthislemme.com and also freemsra.com. Thanks for joining us for this deep dive.